Welcome to the finale, the end. We've reached the end of the road of ESMO 2024, and Josh and I are here because we are going to talk about some of our favourite studies, the best, most practice-changing studies that we have seen live in Barcelona. Josh, how are you going?
I'm good. I'm going to dub this the 5 Fernando finale finishes for our Barcelona adventure.
We're on a bit of an alliteration streak here the last few episodes, aren't we?
Yeah, we really are. It must be because we're just enjoying the sunshine. Michael, who's going to start us off?
Josh, I think you should start us off because you want to talk about the love of your life, prostate cancer.
Or prostates in general. No, just prostate cancer. So this was a phase 3 trial. It was combining radium-223, which is a radioactive isotope, with an androgen receptor pathway inhibitor or androgen receptor signaling inhibitor, depending where you work, in advanced prostate cancer. People were randomized to either radium-223 plus enzalutamide or enzalutamide alone. They were given radium-223 every 4 weeks for 6 cycles, with the primary endpoint being radiographic progression-free survival, and the key secondary endpoints being safety, overall survival, time to next treatment, time to pain progression, and time to first sympathetic, I'm going to say symptomatic skeletal event. My notes are very, very interesting. And I think the thing to really talk about this trial, Michael, this is with patients who are castrate-resistant prostate cancer rather than castrate-sensitive prostate cancer. Is that correct?
That is correct, and I think it's one of those studies where they started recruiting and put together the study design before the landscape changed.
That's it, but there is still going to be, as they said in this discussion, that there is still going to be a need for this trial purely because there are people who cannot access these drugs earlier on due to reimbursement and other such issues. Looking at the baseline characteristics, they are relatively well balanced, except there were more people with a higher ALP enzyme in the enzalutamide alone arm. 30% of patients had had docetaxel prior to the commencement of this trial, and about 4 patients, so not a lot, had had abiraterone in the hormone sensitive setting. When you look at the treatment exposure, 224 patients started enzalutamide, 215 started the combination, and 3 started enza, but not the radium-223. The 24-month radiographic progression-free survival as our primary endpoint, and I'm already there, Michael, was 36% versus 45%, favoring the combination arm, with a hazard ratio that was statistically significant at 0.69. Month-wise, it's about 3-month difference of 16.4 versus 19.4, favoring that combination arm. Looking at the subgroups, there was consistent benefit across those subgroups. Overall survival was also statistically significant with a hazard ratio of 0.69, meaning that there was a 30% benefit of having this particular combination versus single agent enzalutamide in that metastatic castrate-resistant prostate cancer setting. Median overall survival improved from 35 months to 42.3 months in the combination arm. Time to next treatment also significantly prolonged, and at the 24-month mark, time to next treatment was 51% in the enzalutamide arm versus 31% in the combination arm. So essentially 20% of patients didn't have to go to another treatment because they had this treatment. The hazard ratio was 0.57, so almost 40+% benefit. There was no difference between pain progression, no difference between symptomatic skeletal events, and adverse events was high in the combination arm, and there was no death in either arm due to an adverse event. Hypertension, fatigue, fractures, anemia, neutropenia were most common in that combination arm. The other points to note is that they also gave anti-resorptive agent in this particular, and ADT, so they were on that skeletal protecting agent as well. The question is it time? Is it practice changing? I'm going to say yes, especially in countries where you don't have access to these drugs yet. And so that's very, very interesting. When we look at side effects, one other thing to mention with enzalutamide, hypertension occurred in 30% of patients. And so you're probably going to want to start someone or keep a very close eye on their blood pressure. But that was the quickest plenary update of a trial I've done in a while. But it was a great trial, and it actually shows there's an area of need and there is a direct benefit of combination of these two drugs.
I completely agree, Josh. And we were talking afterwards that it would be interesting as well as a future idea, if anyone has a stash of radium and enzalutamide lying around the house, to potentially have the enzalutamide and ADT in the hormone-sensitive arm and potentially start radium at the onset of castration resistance, or move it the whole kit and caboodle into the hormone-sensitive space, as we are seeing with so many other treatments in prostate cancer.
And maybe it'll continue to sit in that podium very high up in our plenary, our plenary hall of fame, Michael. But speaking of podiums and how you like to interact in this world of oncology, do you want to talk about your next trial?
Absolutely. So this is the PODIUM 303 study, and it really does deserve a podium at ESMO 2024. It is a study of anal SCC, and anal SCC is one of those orphan cancers. It's a horrible, horrible disease that, fortunately, if it's caught early, we do have good cure rates with chemoradiotherapy. However, there's always a proportion of patients that will recur and will have distant disease, and at that point, treatment options are very, very limited. Effectively, you only have carboplatin and paclitaxel, and then you're on to phase 1 trials because it's a rare cancer. It's very unusual to have phase 3 trials in this space, but we've got one here. And this is a study of retifanlimab, which is a PD-1 antibody that was combined with carboplatin and paclitaxel compared with matching placebo. So all patients got chemotherapy, but only one arm got the retifanlimab in the first-line treatment setting of advanced anal SCC. It's also important to note that anal SCC, while it's rare, the incidence is increasing, and it's heavily associated with HIV and HPV. And this informs the rationale of this study using immunotherapy in virally driven cancers, because we have a proof of concept for this combination with the results that we've seen in head and neck cancer, cervical cancer, other cancers that are driven by HPV. It's also notable that the study allowed patients with HIV, which was well controlled. The speaker didn't really go into exactly what that meant in terms of CD4 counts, but it's nice to see that HIV patients are not being excluded from a trial. So, stratification factors. Patients were stratified according to their PD-L1 expression, which was given in terms of combined proportion score, or CPS. Important to note that 90% of patients had a PD-L1 CPS of greater than or equal to 1%. Patients were also stratified according to geographic region and extent of disease. Primary endpoint here was progression-free survival. Secondary endpoint was overall survival and overall response rate. Also important to note that there was crossover allowed to single-agent retifanlimab in the placebo group upon confirmation of progression, and 69 patients in the placebo group did crossover. So now we come to the results. The progression-free survival was 9.3 months compared to 7.4 months, with a hazard ratio of 0.63, and this was statistically significant. The overall survival was immature at best, but there was a really nice separation of the curves. The combination immunotherapy and chemotherapy arm had an interim overall survival of 29.2 months compared to 23 months, with a hazard ratio of 0.7. When the authors accounted for crossover, and they did this using some statistical wizardry that I'm not even going to pretend I understood, the hazard ratio for overall survival was actually improved down to 0.63. The overall response rate was 56 compared to 44%. The duration of response was almost doubled, 14 versus 7.2 months. And there were no real new safety signals. You had the expected increase in toxicity, you had the increase in rates of immune-mediated adverse events, but nothing unusual. And notably, there was no loss of HIV control. This aligns with a lot of other evidence, particularly in the hepatocellular carcinoma space, that shows that immunotherapy is safe to give in patients with HIV. So to conclude, this is a great study. I really, really like this study. The primary endpoint has been met, and the secondary endpoint of overall survival looks really, really promising. And so this would be a new standard of care. And Josh, we always like to highlight the great research that's done in cancers that that for so long have been neglected in terms of large phase 3 studies, and this is definitely one of them.
So yeah, really, really exciting stuff, and definitely an unmet need.
Completely agree. Josh, why don't you go right along to our third study in this plenary extravaganza?
Yeah, I think we used extravaganza last time. I think it's Michael's, I forget what I said, Michael's 5 fabulous finishing
Fenestrations.
fenestrations. No, that doesn't work. We'll workshop it. This is a very large name for this study, but it is the ENCOG CX11 GOG 3047 KEYNOTE-522 randomized double-blind phase 3 study. And if you're already lost, I apologize. They didn't have a fancy name that I could find out, but it's to do with locally advanced cervical cancer. The background is when combining immunotherapy to radiotherapy, it can increase the benefits of radiotherapy alone. Improved local control is seen in greater than 90%, and overall survival 5-year mark is 75%. With reduced toxicity in the locally advanced cervical cancer with modern radiotherapy. Pembrolizumab plus chemotherapy for new diagnosed high-risk FIGO stage 2 to 4 cervical cancer. And this is what this is looking at. It's looking essentially the use of this combination treatment and outcomes. So the design, it was FIGO stage 1B2 and 2B node positive disease or stage 3 and 4A. They are randomized to either cisplatin with radiotherapy plus brachytherapy and immunotherapy, pembrolizumab in this case, or cisplatin 5 cycles of radiotherapy followed by brachytherapy and placebo. Note here, the omission is the immunotherapy. They will continue for pembrolizumab for 15 cycles in the adjuvant setting or control. The primary endpoint was that of progression-free survival and overall survival, and the secondary endpoint was 24 months progression-free survival, 36 months overall survival, objective response rates, and other fun things. At the cutoff date, 16% of patients were still on treatment, and 16% in the control arm was still on treatment. 41% completed all of the treatment in Arm A and 33% in Arm B. Baseline characteristics was there was a slightly higher propensity for more advanced disease of stage 3 and stage 4A, and lymph node positivity was similar in both arms. 90% of patients in both arms had had appropriate radiotherapy. The median number of cisplatin was 5 for both arms, and for pembrolizumab was 17, and for placebo was 16. The primary endpoint showed a hazard ratio of 0.70, which is statistically significant, with 21.7% having events in the intervention arm, which is pembrolizumab, and 29% in the control arm. So there was a larger number of events being that of progression-free survival events and overall survival events in the control arm than the intervention arm. Looking at the updated progression-free survival, the hazard ratio was 0.68, and the median follow-up at that point in time was 29.9 months, so about a 30% benefit. The 3-year showed 69% PFS versus 53% PFS in favoring the intervention arm, and what was also interesting, it was most pre-specified group was most benefit was in the stage 3 and stage 4A. The overall survival, which was reported in those treated with pembrolizumab, had a hazard ratio of 0.67. The lines are separating. I'm not sure if it was statistically significant, and I can't see that in my notes, but we'll link it in the conclusion. But I think it is from memory. It was a statistically significant benefit in overall survival and in the pre-specified subgroups. So what they found is that pembrolizumab with modern high-quality chemoradiotherapy and then continued. Michael showing me the p-value was 0.004. So that's great. It also provides statistically significant, meaningful progression-free survival and overall survival, also highlighting really a new standard of care for locally advanced cervical cancer, from stage 2 to stage 4, really, which is absolutely phenomenal. For anyone who has treated cervical cancer, it is a very nasty, nasty disease when it's not treated or when it's advanced. So anything that can control this and control this longer is something that is really, really, really important. And so I dub this as probably one of my favorite plenary presentations, purely because of the morbidity that you get with this cancer.
I completely agree, and I think that we can probably group this and PODIUM as trials that address cancers that really need more options, and this being an earlier phase study is really good because we've both seen cases of metastatic cervical cancer, and they are horrible. Even by the standards of cancer, they're incredibly morbid, so anything that can be done to improve outcomes is great.
That's it, and it shows that there's outcomes, I think, across the board from the stage 2 to stage 4A, so really, really exciting stuff.
All right, moving right along. So the next study that we're going to talk about amongst our best of the best is the final results for KEYNOTE-522. Now, I'm sure everyone listening is familiar with KEYNOTE-522, but for those who aren't, this was a seminal paper that entrenched the role of immunotherapy with pembrolizumab in the neoadjuvant and adjuvant treatment, some might call that the perioperative treatment, of triple-negative breast cancer. A huge step forward given the lack of options and targetable receptors in triple-negative breast cancer. So a quick background, I won't spend too much time on this, but KEYNOTE-522 included patients with both stage 2 and stage 3 triple-negative breast cancer. The primary endpoint, which has already been met, was event-free survival. The secondary endpoints included pathological complete response rate, EFS, and overall survival in the PD-L1 CPS greater than 1%, but most critically, what was presented was the overall survival data, the final feather in KEYNOTE-522's cap. So first off, the updated event-free survival, just to keep our listeners on the edge of their seats just for a little longer. 5-year EFS was 81.2 compared to 72.2%, with a hazard ratio of 0.65. And this is notable because the curves are starting to flatten for KEYNOTE-522. We know that biologically about 90% of recurrences are expected within the first 5 years, with the vast majority of those happening in the first 2. So we really should be at the point where the number of new recurrences is minimal. And now, the most important thing, the overall survival data there.
Some would say it's the final countdown.
The final countdown. We definitely weren't just jamming to that before recording. But this has always been the question, because we've known that it helps with event-free survival, but we've never been able to fully throw our weight behind KEYNOTE-522 until we have that wonderful overall survival data. So, the hazard ratio for KEYNOTE-522, 0.66. That is statistically and obviously clinically significant. 5-year overall survival was 86.6 in the pembro group versus 81.7% in the control group. And we can see that this magnitude of benefit was preserved regardless of whether a patient had a PCR at the start. So if patients did have a PCR, the hazard ratio is 0.69, with a delta of only about 0.6%. So the absolute benefit might be small at 5 years, but you're still getting a benefit. If you didn't have a pathological complete response rate, the hazard ratio is 0.76, but the delta was a shade over 6%. So you are getting benefit with pembrolizumab regardless of how well you do with the initial chemoimmunotherapy. There's no new safety signals, as one would expect. These patients would have been off treatment for years by now. There are a few recurring questions, or remaining questions, I should say, and these largely come from fine-tuning our approach to this regimen, which is now entrenched as the standard of care. Can we predict who gets cured with the immunotherapy? So who really, really benefits from it to the point where they get cured, where they wouldn't have otherwise? Do patients still need the full year of adjuvant IO? And this is a question about what provides a greater contribution, neoadjuvant versus adjuvant. And what is the long-term quality of life for cured patients? We know that, anecdotally at least, KEYNOTE-522 regimen actually has quite a lot of the strange toxicities, the neuropathies and the myopathies, and those weird sort of rare adverse events. They seem to be, if not more common, then certainly more noticeable with KEYNOTE-522. So what are we sacrificing in order to gain this increase in PCR? It's also worth noting, just as a minor thing, that the degree of response is important. We know that the whether you have a PCR or not is you still get a benefit, but for patients who had no response, that's a residual cancer burden ranking of 3 or grading of 3, the prognosis remains very poor with a 36-month EFS of around 30%. So that's just a little bit of a caveat. But regardless, I don't think, Josh, that there's really any reason for us not to be giving KEYNOTE-522 regimen for our triple-negative breast cancer patients.
Only if the size of the tumour is very, very small.
Well, that's true. Or if there's a medical contraindication to immunotherapy. Josh, from one practice-changing regimen to another, tell us about the no-cut study.
A really interesting study, and something that with immunotherapy coming to the fore will probably spread to other tumor types. But the question is, when you have a complete response to a treatment, do you need surgery? So this is looking at total neoadjuvant treatment for locally advanced rectal cancer. This is the standard therapeutic option, TNT. I'm going to summarize it and abbreviate it as TNT, and non-operative management, which they've abbreviated as NOM, after clinical complete response is gaining consensus. After NOM, local regrowth of the cancer is well characterized and stays in about the 19 to 34% range, and distant relapse is not well studied. So the no-cut study is a multi-center phase 2, so it's not a phase 3, but it is a phase 2 trial of those with proficient MMR, which means they're not a candidate for immunotherapy, locally advanced rectal cancer, aiming to assess if NOM negatively affects the risk of distant relapse, and if predictive multi-omics biomarkers or outcomes in tumor tissues and blood samples. So what they want to know is that if you get essentially, you have non-operative management, does this actually increase your risk of having the cancer coming back? So 180 patients were involved, high risk, meaning mid to low rectal cancers, T3 to T4, and a lymph node of 1 to 2 with no metastases, with the proficient MMR, rectal adenocarcinoma, good performance status. They were given induction chemotherapy with capecitabine and oxaliplatin for 4 cycles. Then they were staged with a digital rectal exam, an MRI, and a CT. They then had capecitabine and radiotherapy. That was from weeks 13 to 18. They were observed for a couple of weeks, and then at that point they had repeat imaging, and this is when it diverged. So if they had complete clinical response, then they underwent non-operative management. If they did not, then they underwent, and when I say did they not, they had an incomplete response. They underwent surgery. The NOM cohort had very intense follow-up, and the surgical cohort had the regular standard follow-up. The primary endpoint was the percentage of patients alive with distant relapse-free at the 30-month mark. And the secondary endpoint was those that had, clinical complete response, organ preservation, and organ preservation rate in the NOM patients. So between June and August, 180 patients were enrolled. The median follow-up time was 27 months, out to about 68 months, and 1 death was due to toxicity. And overall, people generally had a higher clinical T stage, so a larger sized tumor. And when you look at the results, 26% of patients achieved a complete clinical remission and proceeded with the NOM protocol. 90% of patients who had an incomplete response underwent surgery. The T stage was confirmed and as a clinical predictor for complete clinical response, and the tumor location at low was associated with a response. The primary objective showed that in NOM patients, the distant relapse-free survival was 96.9% at 30 months. And in the all patients, which included those that had an incomplete response, the distance relapse-free survival at 30 months was 76.7%, confirming that this is a potential option for patients who do have a clinical complete response. The secondary objective was organ preservation rate. These sorts of surgeries can have quite a high morbidity, and organ preservation rate was 85% in those that had complete clinical response. All patients with local regrowth underwent rescue surgery, and 42% were sphincter pairing. Sphincter sparing, not sphincter pairing, Michael. They also did a bit of translational research. And what does that mean? They did ctDNA biopsies initially at the start, and then after the definitive chemoradiotherapy and before surgery or observation, and they had follow-up time points. So a negative ctDNA was associated with a good tumor response. The ctDNA status after treatment, but before surgery, did predict clinical response and distant recurrence-free survival with a hazard ratio of 3.23. So what I mean by that, I find these always really difficult to discuss, but the 3-year distant recurrence-free survival, if you had ctDNA negative, it was 85%, but if you were ctDNA positive, that dropped to 64%. And then if you again look at the ctDNA after surgery, it also helped predict PFS. So in the 121 patients who underwent rectal surgery, the 2 and 3 year progression-free survival was 68% and 66%, whereas the PFS, according to ctDNA, if it was negative, was much higher, with a hazard ratio of 6.99. So I think you were 7 times more likely to have progression if you had positive ctDNA. So what does this no-cuts trial? It showed that non-operative management could potentially be an option. It also highlights that you do have to select your candidates to take, and you need to take advantage of translational biomarkers. Is this mainstream with only a phase 2 trial? Potentially, and I think over time we will see this be the standard of care because less surgery, less morbidity, and if intense follow-up is what you need, then that's absolutely wonderful for the patient, the clinician, and our healthcare system.
Completely agree. And in some centres, they're sort of already doing this, taking a preferentially non-operative approach for patients who have pathological complete response. So there is some anecdotal evidence to this approach based on the Oprah study, which didn't actually look at survival outcomes. It looked at the capacity to preserve or to undertake a non-operative approach.
There's one last thing I need to say, Michael, before I let you finish off the final frontier. I think I say this every time, the final 100 meters that we waddle along towards we get to that finish line, is that it did highlight also they need to look at ways to increase that clinical complete response. It's still not that high.
Yeah. You wonder whether using something like folfoxiri instead of Kpox might increase that, but we don't know how much benefit is irinotecan going to have. Anyway, we come to it at last. The great battle of our time. To quote Gandalf the White. I don't know where that came from, to be honest, but the last study that we want to talk about, and for my money, probably the most impressive study in so many ways for ESMO, was the NIAGARA clinical trial. Now, this is a study of urothelial cancer, muscle-invasive bladder cancer. 50% of patients with muscle-invasive bladder cancer will relapse and die within 3 years. NIAGARA took a perioperative approach, adding durvalumab to the usual regimen of cisplatin plus gemcitabine, followed by surgery, and then followed by adjuvant durvalumab, so neoadjuvant and adjuvant. This is thought to prime the anti-tumor immunity prior to surgery, and then the adjuvant immunotherapy eliminates micrometastases. Very similar approach and very similar sort of biological rationale to what we've seen in breast cancer and in melanoma recently with NADINA. The first thing that really impressed me about this trial was how many patients they recruited. They recruited 1,603 patients, which is really, really hard because bladder cancer is a really morbid disease, and the typical patient that has bladder cancer is comorbid. Crumbly is the word that we often use. It's the classic elderly gentleman, ex-smoker, lots of comorbidities. So getting that many patients is really impressive. As mentioned, patients were randomized to receive durva plus cisgem versus cisgem alone in the neoadjuvant setting. And then in the adjuvant setting, they had durvalumab or nothing. The primary endpoint was the pathological complete response rate and the event-free survival. There were dual primary endpoints. Patients who did not proceed to surgery, so for whatever reason, if a patient did not undergo a cystectomy, that was considered an event. It was counted against the event-free survival. Majority of patients had greater than T2 primaries, so large primaries. Only 5% did have nodal disease, even though they did allow for patients with N1 disease, and obviously they had to be free of metastases. We come to the results. The event-free survival had a hazard ratio of 0.68. It was clinically and statistically significant with a p-value of less than 0.0001. The 24-month event-free survival was 67.8 in the control arm versus 89.8% in the durvalumab arm. I wrote those the wrong way around and I almost tripped myself up, but I recovered. There you go. The pathological complete response rate was 37.8 in the durvalumab arm compared to 28.8% in the control arm, with a p-value of 0.003. This did not reach statistical significance because of the statistical design and the alpha value required. However, it is still numerically significantly better. Perhaps illustrating the poorer prognosis of urothelial cancer compared to breast cancer, KEYNOTE-522, we've had to wait many years for overall survival. With NIAGARA, we have it straight off the bat. So the hazard ratio for overall survival is 0.75 with a p-value of 0.01. The 24-month overall survival was 82.2 compared to 75.2%. Safety was very similar across both groups. The rate of grade 3 to 4 adverse events was 41% in both arms. Adverse events leading to failure or delay of surgery only occurred in 3 and 2% of patients respectively, so it's nice to see that the addition of durvalumab does not delay or prevent people going to surgery. Interestingly, the most common reason for patients not undergoing surgery was patient choice, which is understandable. A radical cystectomy is a huge procedure, leaves you with an ileostomy bag for the rest of your life. It's not very pleasant. So to conclude, NIAGARA shows that the addition of durvalumab to a perioperative approach to muscle-invasive bladder cancer should be considered a standard of care. It's a hugely impressive study in so many ways, not just the results. The fact that they were able to do it in the first place is great and really does seem to cut into that likely 50% relapse within 3 years. It's very, very exciting, and I hope to see this rolled out in clinical centres everywhere, anywhere that you can get access to durvalumab, really.
I think that's it, Michael. Really exciting. But can I raise the questions?
Of course you can.
There are so many questions, though, because you've used immunotherapy. So if they recur, which there is still a number of patients who do recur, what do you do? Can you then re-challenge them? Will it still have the same effect? This is sort of an unknown. Also, the people that are, you probably just spoke about this, but like cisplatin ineligible, how does this impact their kind of outcomes? Can you switch off a carbo? Like all those questions, I don't know. Just complete pathological response, improve, long-term outcomes. Another question, I don't know if I have my full grasp on it. And I know the time and we've got to get to a dinner because it's the last night in Barcelona, but they're really great questions. I mean, I think they're great questions, but they're things that pop into my mind about how do you kind of sequence these things and what happens if they then just progress despite that.
I think I agree with you, Josh. They're all really good questions. I mean, with EV302, the option would be to just use EV301, it'd probably be. The option would be to just use EV in the first line, plus or minus Pembro, depending on local availability. But also, you would probably be looking for additional biomarkers. We've talked about FGFR in the bladder cancer space. That's quite promising, we hope. But further treatment options would then be needed. The cisplatin ineligible question, huge issue. We know that carbo in this instance is actually inferior to cisplatin, so there's no data that supports a carbo to cis or cis to carbo switch. That wasn't included in the trial. So this isn't going to be for everyone, but for those who can get it, I think it's great.
I think that concludes our mega marathon of our Barcelona edition of ESMO 2024.
It's been absolutely wonderful to be here for the first time in person, and it's been a great honor to rub shoulders with giants, I think it's fair to say. Sometimes literally, because the convention center was packed at times, but it's been a great experience.
That's it, and we look forward to bringing you a further analysis in a couple of weeks where we get some of those greats to come on our show and give us their take on the main tumor streams and what makes them get excited. I think that's it. But until then, have a lovely week, and we can't wait to bring you more soon.
Bye. Thank you for listening to Oncology for the Inquisitive Mind. This episode was produced by ADC Productions, with the assistance of education grants from Pfizer, Gilead Pharmaceuticals, and Merck Pharmaceuticals. However, we do not allow creative or editorial control or even early previews of any content. They are hearing this episode alongside you for the very first time. If you like this episode, there's plenty more where that came from. Check out our website, inquisitiveonc.com, for all of our previous episodes, and make sure to subscribe to be the first to hear new content. If you'd like a particular topic covered on the show, or just want to chat, drop us a line on Twitter @InquisitiveOnc, or by email on inquisitiveonc@gmail.com. Thanks for listening, and we'll see you next time.